Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and vaccine chapter immunization representative for the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. This is the week of April 12th, 2021. And as of today, when I'm recording this, April 13th, there are over 137 million total cases of COVID-19 since the start of the pandemic globally, with 2.95 million deaths from that. In the United States, 31.3 total cases since the start, 31.3 million cases since the start of the pandemic, with almost 563,000 deaths in the United States alone. Kids specifically, as of the American Academy of Pediatrics report on April 8th, so just last week, there are 3.54 million total cases in the pediatric age range, which constitutes 13.5% of the total cases and an average of 4,707 per 100,000 pediatric patients. Putting that into perspective then, here in Arizona, since the start of the pandemic, we have had 136,160 pediatric cases of COVID-19, which here is 16.1% of the total number of cases and comes out to 7,405 cases per 100,000 pediatric age range in Arizona from birth through age 17. We remain steady at 28 pediatric deaths related to COVID-19, second only still to Texas with 49 deaths. So the numbers continue to be significant. The numbers have slowed down and in many parts of the country plateaued, especially in Arizona, where we are thankfully at a much lower attack rate, and our weekly trends have been down, to the very least slightly down, and that's wonderful. However, the impact potentially of pediatric and unaccompanied minors coming across the border with the recent influx in immigration it's an unknown, since the Border Patrol and the federal government so far have not been screening or testing those individuals for positivity. So it may be that we have an influx of cases we just don't know about, but at the very least, Arizona is not in the top 5 states in the country known for their highest attack rates, those being states such as Michigan, Texas, and Florida. So again, a great list of questions to go through, and most of these have to do with the vaccines. We'll start with one involving the Johnson & Johnson vaccine, or Janssen Pharmaceutical. And this question is asking that the J&J vaccine causes fewer side effects in individuals than the messenger RNA vaccines produced by Moderna and Pfizer. Why would that be, and how can we help patients' families access the Johnson & Johnson vaccine? Well, unfortunately, since the time this question was written and I received it, and up to today, things have changed a little bit. There now are reports in this country and also elsewhere in the world of a clotting disorder, this time affecting the cerebrovascular region, related to, or potentially, I should say, related to vaccination with the Johnson & Johnson vaccine. This follows, unfortunately, the cluster of reports from the AstraZeneca vaccine. Keeping in mind that both Johnson & Johnson and AstraZeneca's vaccines are the same construct, meaning a modified adenovirus vector to which has been inserted the code for the spike protein of SARS coronavirus 2. It appears in some individuals that both vaccines precipitate an autoimmune or an immune attack on the heparin and or platelet factor 4, which causes something similar to heparin-induced thrombocytopenia followed by coagulopathic stroke. This would only occur in a certain very small number of patients who are previously set up or sensitized to have this reaction triggered by their immune reaction to the specific adenoviral vectors. So, out of an abundance of caution, and this is appropriate and indeed an abundance of caution, all states, and including Arizona, are now pausing vaccination with the Johnson & Johnson vaccine until these reports can be further investigated and the true either causal reality and or potential risk can be better described. Prior to that time, there were a lot of elements of the Johnson & Johnson vaccine that made it quite palatable. It's a single shot. It's not completely new technology, such as the messenger RNA vaccines, although it is relatively new. And indeed, there were fewer reports of side effects. However, it's important to note that many of the reported side effects with Moderna and Pfizer had to do with a very robust immune reaction, especially after the second injection. Johnson & Johnson's vaccine is a single injection, and so it just had one, pardon the pun, shot at creating post-injection side effects. So it may be that we're one to get a booster with a Johnson & Johnson vaccine, that the side effect profile would be more significant. However, it is also possible that the actual immunity, meaning immune response, to the Johnson & Johnson approach to vaccination is less immediately robust than that generated by Moderna and Pfizer with the messenger RNA vaccine approach. And thus, the side effects we're seeing after those two shots are more significant only because the immune response is like from 0 to 100 miles an hour in the space of 24 hours. Remains to be determined, but unfortunately that's about all that I can offer regarding Johnson & Johnson's vaccine at this stage. Should it be cleared of causal harm related to the cerebrovascular and or sinus thrombosis and vascular thrombocytopenia, then likely most distribution sites will again be releasing and using the Johnson & Johnson vaccine. And at some point, hopefully, as we have said before in this podcast, those of us in practice with the ability to provide vaccines will hopefully be given a license and permission to do so. Since we all know, and this is not just hubristic thinking, we all know that pediatric practices are the best situated to deliver vaccines to the highest number of people and to address the concerns of vaccine hesitancy. So that is a lovely segue into a next question, which is, what is the best way to discuss the COVID-19 vaccine with hesitant families, presumably vaccine hesitant, although there are going to be families, unfortunately, who may still be in doubt about the truth of the virus itself and the pandemic. And I don't have any magical answers here. I think the recommendations are the same as all of us would offer for any vaccine hesitant family, and that is to have a very focused, supportive, and almost expectant conversation with the families, taking the tone that the vaccine is this is what we're going to be doing. This is part of this routine visit, with the expectation that vaccination shall occur, and then responding clearly, transparently, and honestly to any concerns raised by the families. Some additional notes just for my own personal approach, and I've had some of these questions come to me as well. One is to note that a possible motivator for our patients and their families who indulge in or participate in, is the better term, participate in what we would call pseudoscience, i.e. those who think, well, medication X, even though there's tons of scientific evidence that says it doesn't work, I still believe it works. Why would somebody believe that approach? And new research is suggesting that there is a population of people, perhaps many, who have that degree or that sense of being special. I know something the rest of the world, the rest of the city, the rest of my family does not know. I'm going to get ahead of the curve, and I'm going to get that medication first. Well, in a bizarre way, we could potentially use that in our favor to support vaccination against COVID-19. Yes, we've been rolling out the vaccine to adults and actually ages 16 and up. Yes, Pfizer just submitted its data to the FDA to create an emergency use authorization for age 12 and up. All fantastic news. We can anticipate Moderna is going to follow shortly. And so the tech might be, look, there's this vaccine which has been proving successful at protecting our most vulnerable patients, including grandparents, et cetera, and so forth. There's this new literature that you can get in on and actually get your kid vaccinated first to really protect them against the rest of the world. Wouldn't that be fantastic? It'd be great if it would work that way. I'm probably being a bit of a Pollyanna in that approach, but it's worth a try. And again, it's the expectation, look, the vaccine has now been licensed and approved for use in kids. Now is the time to get it. and potentially to rope in the societal awareness component. The only way through this pandemic and all these pesky requirements to wear masks and socially distance and avoid birthday parties and sports events, etc., is to vaccinate everybody who's at risk. And that means the last vulnerable population are our school kids and even infants. So perhaps pulling on the you can help the rest of the world and yourselves get out from behind the mask if you get your kid vaccinated today. I think also, and this is to the transparent conversation for the vaccine hesitant family, to anticipate that they're going to be concerned about the novelty of the vaccines, especially Moderna's and Pfizer's products, but also to a certain extent the Johnson & Johnson and AstraZeneca's vaccine, should that ever be licensed for use in the United States. So to that end, even before they have time to say, I don't trust it, you can say, there are some who have who have concerns about the novelty of the vaccine. However, I need to point out that the science and the use of this vaccine technology, messenger RNA, has been in use for at least the last 10 years. Certainly, vaccines used and anticipated to be used for the Ebola outbreak in West Africa in 2014 used this technology. Others as well have been deployed. So this is not new technology. Also, there is zero way for messenger RNA given in a vaccine to in any way affect the DNA. So it's physically impossible to create a genetic mutation and grow a third arm or a third eye or something like that. I have certainly heard anecdotal reports of families and adults certainly who have fears about the government's support of the vaccine and how the government will use tracers or probes or something like that. I don't have a magical approach for how to address those fears, because of course we think they're nonsensical. But yet, on the other hand, we could simply say a lot of individuals in this country and globally have been vaccinated, and there's been no increase in government hostile activity related to that. I am sure many of you have a lot more practical experience than even I in how to handle these conversations. And just like we do with other vaccine hesitant issues, adolescent immunizations, for example, even primary series, this approach I think can be or should be the same. Somewhat related, the questioner asks, has there been any indication that high schools will require students 16 and older to have a COVID vaccine prior to starting the next school year? This, of course, touches very closely on the concept of immunization or immunity passports. And I would suspect most of us have seen a lot of this playing out in the media. The federal government and certainly Arizona state government have zero plans to introduce and certainly to enforce a vaccine passport. And I have certainly heard no messaging and seen no indication that any school districts are considering the same. Of course, like in many other vaccines, the vaccines will be suggested, recommended, as a way to reduce the risk to the entire student body. But with very rare exceptions, there are very few vaccine requirements for school entry or re-entry. And even for those vaccines, of course, that are very appropriately required, i.e. primary series, et cetera, and so forth, there will always be the potential for medical and personal belief exemptions. Arizona, this is a negative, but it's going to sound like a positive. Arizona state legislature is a huge supporter of personal belief exemptions. So it is very easy for a family who chooses not to vaccinate their child to still be able to send their child to school. So very long answer short, I don't see and I have not seen an indication that there will be a requirement for COVID vaccines for school children returning to school for the next school year. As a note of hope, and a corollary to this, is that vaccine studies have now gone down to age 6 months and up. Those of us who practice in the Phoenix metro area are aware that Moderna vaccine trial is recruiting 2 studies for ages 6 months of age and up through age 12 as safety and efficacy studies. It is very likely that data will be achieved quickly and submitted to the FDA by this summer in anticipation of an emergency use authorization for 6 months of age and up by next school year. That's a stretch goal, to be sure, but I think it is reasonable to think that may happen. Certainly by the end of the year 2021, I think it highly likely that we will have a confirmed pediatric indication, finally, for at least one and hopefully several COVID-19 vaccine products. Okay, next set of questions. Why have more women gotten the vaccine than men, and does this impact population immunity? This is a fascinating question, and I didn't have personal insight, so I needed to do some digging. And as it turns out, this issue is certainly not related just to Arizona, but it is a national finding, and actually in developed countries, it is a global finding. And there are several hypotheses offered. First of all, is that, and I'm quoting from studies I just reviewed, 75% of healthcare and education workforce are women. And of course, those two areas, healthcare and education, were prioritized for early vaccines. Certainly healthcare workers, and now our educators, staff personnel, administrators. So just because the way we prioritize vaccine delivery in the United States, that would preferentially select women to be vaccinated first, and certainly more in terms of numbers than for men. Another observation, which has been known for quite some time, is that the life expectancy of a woman in general, unrelated to COVID-19, is longer than that for man. And yes, you could all think, as have I, of environmental reasons, behavioral issues, etc., and so forth. It turns out this discrepancy is even more exaggerated when it comes to COVID-19 infection. A majority of COVID-19 deaths have occurred in men, leaving women as long-term survivors. If you then look at the older ages that were first prioritized for vaccine, there would be more older-aged women survivors after the first three surges of COVID-19 in this country available to get the vaccine when they were prioritized. And then finally, and this again goes back to societal research, women are far more likely to be in a role as a caregiver, and thus both identified to receive vaccine and also have a personal preference to be vaccinated to protect the person they're giving care to. And similarly, women societally and behaviorally are far more likely to seek preventative healthcare interventions than are men. So that's a whole bunch of reasons that I feel likely explain why we're seeing a significant majority of vaccine recipients for COVID-19 as women. So does this impact population immunity? That's, of course, a much more difficult question to answer. I think it probably does not. If you sort of take the same tack, that is, those individuals who are providing care, who are teaching, and therefore more in harm's way in terms of acquiring disease and therefore propagating disease, if all those are more likely to be women than men, then it's a good thing that women are more likely to have been vaccinated against those. On the other hand, we all know, and I'm speaking as a man, that men are more likely to be risk takers and to have behaviors that are more likely to propagate disease, i.e. COVID-19, sexually transmitted infections, etc., and so forth, than are women. So if that's true, then it would suggest that there's no major impact to vaccinating more women than men, other than to protect those who are vulnerable. How those two issues feature out, and quite honestly, there are many more that I honestly have not wrapped my mind around, is very difficult to predict. So I have a strong sense, and anybody who has closely studied the science, the evidence, the history so far of the COVID-19 pandemic is absolutely feeling that in 5 years' time, we will look back on this time with so many more lessons learned and so much better insight. So stay tuned. If I'm still giving this podcast in 5 years' time, maybe I'll have an answer by then. Next question. Why are children's cases increasing so much? Shouldn't adult vaccination act to protect them? And could it be the variants? Well, it's debatable whether children's cases are truly increasing in relation to population dynamics or are a delayed effect of their adult parents or exposures at home having been infected. It is absolutely true that pediatric cases lag behind the adult cases in each of the last 3 or 4 surges by as much as 2 to 4 weeks. It is also true that pediatric cases are far more likely to be asymptomatic or mildly symptomatic and not come to medical attention. However, those kids who do get sick and are brought to medical attention more often than not are experiencing a post-infectious reaction, such as the multisystem inflammatory syndrome in children, the MISCs, or some other hypervirulent form of COVID-19. And it may simply be that as the yet remaining unvaccinated population, those kids at risk for hypervirulent or severe COVID-19 are now finally being infected, regardless of whether their families have been vaccinated or not, because they're being exposed to the virus in other aspects of the community, or combined sporting events, or birthday parties, or even school. It is still true that at least in kindergarten through fifth grade, that elementary age children are not still yet known to be highly contagious or to be likely risk factors for spreading SARS-CoV-2. That is not true, however, of middle school and high schoolers, in which there is a higher risk approaching or even exceeding that of young adults. So it may simply be that the failure to vaccinate children and adolescents, adults, or young adults, along with the rest of the population, is precipitating an at-risk population that we are now seeing the impact of. Could it be the variants? Yes, it could be. As things currently stand, the research and awareness of the mutant variants has not progressed too far since the last time I recorded this podcast. Circulating in the United States are the four most commonly identified variants that so far have been described. And those are, in order of description, the UK strain, the B1.1.7, the Brazilian strain, the P.1, the South African strain, which is the B.1.351, and then the Southern California strain, the Cal.20C, which has mutations seen in both the South African and the United Kingdom variants. To date, all those increase the infectivity or contagiousness of those viruses. However, it's only so far the South African variant, the B.1.351, that is showing an increased predilection and contagiousness in pediatric patients. So far, and thankfully, that is the least commonly identified variant in the United States. So, for right now, today, April 13, 2021, the variants existing in this country, and the UK strain is now the predominant one of all the strains, are not known to make children more infectious. And therefore, we cannot blame any increasing number of cases either related to schools opening or to kids infecting others. That may change, however. And again, this is an incredibly dynamic pandemic, and a lot is happening in a very short period of time that we're aware of because we're looking for it, we're screening for it. So ask that question again in 4 weeks, and the answer may be different. We'll find out. And then the last question that I have is, how does natural immunity from previous infection compare to vaccine immunity? So, as it turns out, natural infection or natural immunity from having been infected with the coronavirus should be raging monster immunity driving. And we take this from our experiences with individuals who experience pertussis, wild type pertussis, versus getting inactivated vaccination against that. And an infection with an infectious agent historically has always driven a much more robust, much longer lasting immunity, which is protective. It appears that is not so in the setting of SARS-CoV-2 infection with COVID-19. And it's unclear exactly why that may be, but the current suggestion is that wild type disease, so experiencing COVID-19, does indeed provide immunity against many antigenic elements of the SARS coronavirus 2. However, that immunity is while not robust, it's solid, but it can dissipate and resolve much more rapidly than one would normally expect for a wild type infection. Compare that to the immunity driven by one of the current COVID-19 vaccines, which is providing exposure specifically to the spike protein. This is the business end of the SARS coronavirus 2. And each of the vaccines that have been created and are currently in use and or licensed for use have created a monster immune response, like a huge spike of antibody to that spike protein specifically. which just from the sheer caliber of the amount of immunoglobulin generated takes a long time to slow down, to be excreted, to dissipate. So the immunity from vaccines specific to the spike protein, which gets in the way of vaccine binding and efficacy, is much higher, much longer lasting from vaccine than it is from wild type. Hence the recommendation, even for those who are COVID-19 survivors, to go ahead and proceed with vaccination. And the timing is just 10 days after onset of symptoms and or diagnosis with COVID-19, based not on any immunologic reason, but simply on that individual not being contagious to the vaccine delivery system, i.e. vaccine distribution sites or patient's physician's practice. So there you go. Vaccination remains the best way to get and have protected immunity against the virus. One additional note, and here we have to delve a little bit into immunity and immunology, I should say, and I promise to keep it short and hopefully simple, that there are sort of very, very basically speaking, two types of antibodies. Of course, they're all immunoglobulin G is the one which is long lasting, and of course we initially make immunoglobulin M, and those of us with mucosal issues make immunoglobulin A. But the immunoglobulin G, the long lasting one, which we hold on to memory of how to make, can exist in two different functions. One is to help the adaptive immune system, the cell-based immune system, do its job better. And boy, there's a great, Magic School Bus episode where little Ralphie gets group A strep, and they show the antibodies covering these strep pyogenes bacteria and allowing the phagocytes to munch on them. So indeed, those are opsonizing antibodies which help coat and identify the pathogen, in Ralphie's case, group A strep, as something to be chewed up by the phagocytes. That's part one. Part two, though, is neutralizing antibodies. Keeping in mind that antibodies recognize the active binding site or the active antigen site of the pathogen, group A strep, or as bringing it to current, of SARS-CoV-2. And in so recognizing, if they recognize it and bind to it very strongly, they're going to prevent that binding site for SARS-CoV-2, the spike protein, from binding to its target, the ACE2 receptor on epithelial cells. That neutralizes the ability of the virus, in this case, to bind to its target cells, kill the cells, and do its damage, and precipitate the disease we know as COVID-19. So neutralizing antibody function is different from opsonizing antibody function, and it is the neutralizing antibody function which for COVID-19 can be so powerful if you have high levels of that antibody. Wild-type infection with SARS-CoV-2 is great at producing the first type, the opsonizing antibody, but the neutralizing antibody levels dissipate quite rapidly. Versus vaccine, which creates monster immunity, including high levels of neutralizing antibodies and the ability to make more neutralizing antibodies should the body be re-exposed, so that the vaccines create a much more useful form of immunity than wild type. So that's the difference right there. And once again, just to reiterate, CDC, FDA, science organizations, you name it, everybody, every organization is in favor of immunizing even those who have had proven COVID-19 in an attempt to give them long-lasting neutralizing immunity, which will protect them from secondary infections or repeat infections, which indeed have occurred. So there you go. That's it for the immunology lesson. As always, thank you for listening to IED Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. As always, thanks for listening. Thank you for your questions. Keep sending them in, and hang in there, folks. Hang in there.